Hello, this is Dr. Lawrence Bureau. Welcome to a brief talk on the psychiatric interview. By the end of this talk, I hope for you to have an approach for the interview of a new psychiatric patient, consider the differential diagnosis and screen for major psychiatric illnesses for new patients, and lastly, be able to perform a brief safety screen to make sure your patients are safe when they leave the door. Many students find the acronym MOST to be a good tool to remember the psychiatric differential diagnosis. So with the patient at the center, you can think of the major categories of psychiatric conditions. M for mood, O for organic, A for anxiety, P for psychosis, and S for substance. Within these, you can think of the major conditions. So for example, in mood, patients can be down for depressed, or they can have an elevated mood for manic, which is frequently the important component of bipolar. For organic, it might be an underlying medical condition, things like sepsis or dementia. For anxiety, there's generalized anxiety disorder, PTSD. Some people have panic disorder, and there's obsessive compulsive disorder. For psychosis, there's the frequent hallucinations and delusions, which come to define schizophrenia, schizoaffective, delusional, and many other disorders. And in regards to substances, there's alcohol. Alcohol abuse is remarkably common, and there's many other substances from marijuana, cocaine. The list goes on. The DSM-5 does its best to categorize these diseases. However, to some extent, it tries to take our patients and place them in boxes. This is useful to the extent that it helps us understand our patients. It helps us guide therapeutic choices and allows us to choose the most appropriate medication. Furthermore, it helps us communicate with patients and other health professionals about what is going on. But patients frequently present in ways that are not perfectly explained by the DSM-5. They might have multiple symptoms relating to different conditions. All these conditions to some extent exist on a spectrum. The line we draw between schizophrenia, which is primarily a psychotic disorder, schizoaffective, which is psychosis with a worse degree of mood, depression with hallucinations, which is mood with a bit of hallucinations thrown in, and a pure major depression without any psychosis is to some extent arbitrary. This is why it's important to keep an open mind, and just because you feel you've diagnosed one condition in your patient, you should be thinking about other conditions the patient might also have. This is the approach I use for the psychiatric history. It was taught to me by a third-year resident when I was in medical school. I'm certain this person is currently a psychiatrist practicing somewhere. Unfortunately, I have no idea what his name is, so I cannot give appropriate attributes to him. But I salute you wherever you are. So, firstly, I take my page and I turn it on the side. And nextly, I write ID. And I make sure I have the chief complaint, followed by the HPI. Under the HPI, I ensure I go with an OPQRST format to sort of understand their story. I make sure I also fife them. I got a past medical history, family history, past psychiatric history, family psychiatric history. I make sure I have a good medication history and allergies. In regards to their social history, I take this serial approach, which I'll get into later on. And finally, I do a significant amount of screening for other psychiatric conditions. Some of this gets broken into the HPI, and some of it is purely screening. So everyone gets a M-Siggy caps and a MOPES. And finally, I screen everyone for trauma, and I do a safety check. And taken as a whole, this is your psychiatric history. Now I'm going to go through it into a little bit more detail. The chief complaint for patients with mental health challenges can be quite interesting and not always straightforward. Sometimes patients do come in complaining of feeling depressed or having anxiety. But this is not always the chief complaint that patients present with. Sometimes their mental health issues manifest in physical complaints. They complain about headaches, or they complain about abdominal pain. Or sometimes they just complain about feeling just dizzy or unwell. Sometimes sleeping is the major chief complaint. Mental health disorders manifest in many different ways. I had a patient once come in simply because he wanted a checkup. His family told him it was necessary to see the doctor, and he had no insight that it was not normal to be getting special messages from the number 7. He had lost 30 pounds because he was fearing that people were poisoning his food. As such, you have to listen to your patients, and sometimes the complaint they come in with may just be a manifestation of a mental health issue. The history of presenting illness in a psychiatric visit can be quite challenging because everyone is unique and everyone comes in with a different story. Generally, the history is dependent on the underlying pathology or mental health challenge the patient is having. Follow the OPQRS system you've learned about previously and look at alleviating and exacerbating factors that affect the patient's mental health challenge. Apply this as reasonably as you can to the patient's story. By the end of the history, you should get an idea of what the patient's story is. You should have some sense of what the beginning is, what the middle is, and what the end is, and how they all connect. You should look at the patient and be able to understand most of the major spheres in their life, and be able to draw connections between them, and have some sort of idea how their mental health challenge impacts them and impacts the important things in their life, looking at them in sort of a inclusive type of manner. We'll take a closer look at the spheres shortly to help give you some direction on how to understand their story. As part of the HBI, you should continue fifing your patients. This will give you valuable insight into their perceptions about what is going on. Ask them about their feelings on their feelings. How do they feel about being depressed? How do they feel about having a large amount of energy and having symptoms of mania? Ask them about their ideas about what's going on. This will give you valuable insight into what their level of insight is. Ask how their mental health challenge is affecting the major aspects of their life. And finally, ask about what their expectations about how they can be helped. Some patients come in looking for medications. Some patients come in looking for counseling. Some patients just want help. The past psychiatric history is particularly important in the interview. It will give you some idea about what's been done before and what has worked and what hasn't worked. Get an idea of what the previous diagnoses have been. What were the dates? What were the treatments? What medications have they been on? Which ones worked? Which ones did not work? Has this patient been previously hospitalized for a mental health challenge? If so, how many times? What were the number? What were the duration? And what was the outcome of the hospitalization? Did they go home with supports Were they followed by some community resources? Ultimately, was it helpful, or did it change things in the long run? And lastly, make sure you ask about suicide attempts. Previous suicide attempts is a major risk factor for future suicide. Likewise, you can ask about the number, ask about the methods, and inquire about the lethality. Did they end up seriously hospitalized because of their suicide attempts afterwards? The family psychiatric history is particularly important in the interview because psychiatric illness can run in families. So, for example, as you can see here, Maggie shot Mr. Burns. Well, Mona is being hunted down by the FBI. So you can see a criminality that falls in the family. Well, Homer and Bart both have academic challenges in their education. Jackie and Marge both have funny hair. Abraham Simpson possibly has PTSD, followed by his episodes in World War II. And lastly, Patty and Selma are just plain mean. Some of the Simpsons clan has somehow tended to avoid this. Herb is off making lots of money somewhere. Well, Lisa will one day be president. Well, I'm reasonably certain that in 2045, Ling will be the first person to walk on Mars during Lisa Simpson's presidency. I use the serial acronym to take a social history. This ensures that I'll hit upon most of the major aspects. S stands for school. Are they going to school? What kind of schooling have they had? E stands for employment. How do they support themselves financially? Are they working? Are they not working? Are they on employment insurance? Are they on disability? Are they on workers' compensation? What are their relationships in their life? And this is quite broad. It can include family, friends, intimate partners. What interests do they have? What are their hobbies? What do they like doing? What are the substances of abuse that they might use? This is also quite broad. Include smoking, ethanol, and other recreational drugs. From marijuana, cocaine, ... And finally, legal issues. Has this person been in jail? Have they been arrested? Has their mental health issue caused them to have some sort of interaction with the legal system? For all these things, it's important to not just look at the specific components of their social history, but also see how it interacts with their psychiatric history. Because of their mental health challenge, are they having difficulty meeting the obligations of school or the obligations of employment? How are the relationships with their friends and peers and family affected by their mental health challenge? I also think it's important to screen for intimate partner violence when you're taking a history. Intimate partner violence is far too common, and it can manifest in many different ways. I'll ask a patient, are you in a relationship of dignity and respect? I think this captures the many different ways that this violence can occur, from physical violence to sexual verbal, financial, dot, dot, dot. In regards to review of systems, I think everyone should get an MSIGI CAPS. And this is the diagnostic criteria for a major depression. M is for mood. How is your mood? S is for sleep. Are you sleeping well? Are you having trouble sleeping? Are you not getting enough sleep? Are you getting too much sleep? I is for interest. Do you still find activities that you like to do interesting? Do you still get pleasure out of your activities? G is for guilt. Do you have feelings of excessive guilt? Does the word guilt have any sort of special meaning to you? E is for energy. Do you feel like you have your normal level of energy, or do you have enough energy to do your day-to-day tasks? C is for concentration. How's your concentration level? Are you still able to concentrate while reading the newspaper or doing things? A is for appetite. Are you able to eat? Do you find you have good appetite? Have you gained or lost weight one way or the other? P is for psychomotor retardation. Do you feel like you're slowing down? Do you feel like you can't move as quickly? And S is for suicidality, which we'll touch on in a bit. Of note, to diagnose a major depressive disorder, you need either depressed mood or lack of interest in activities that you used to have, or lack of pleasure from activities that you used to have. I'll now move on to the screening questions I use to look for different psychiatric conditions or different symptoms. Many patients with bipolar 1 or 2 spend most of their time being depressed rather than being manic. So if you look at their entire time in their illness, a small wedge represents how often they have feelings of euphoria or increased mood. Most of the time they're actually being depressed. So although you may see a patient who has depression, they might actually have bipolar 1 or bipolar 2. The way I screen for this is by the following questions. Although you are feeling down right now, has there been a time in your life when you felt euphoric, extremely talkative, had a lot of energy, or a decreased level of sleep? This will usually capture symptoms of mania. If they say yes, you can explore it in more detail. To screen for generalized anxiety disorder, I simply ask if the patient feels anxious or worried about things. In regards to panic attacks, most patients know what panic attacks are. So I'll simply ask, do you have panic attacks? If the patient needs some clarification on what a panic attack is, I'll often describe the symptoms of one, and patients usually understand what I'm leading to. Obsessive compulsive disorder is easy to miss if you do not screen for it. OCD consists of obsessions or thoughts that cannot be controlled, such as the door is unlocked, the door is unlocked, the door is unlocked, which leads to compulsions or actions that try to alleviate these obsessions, rechecking the door over and over and over and over and over again. The question I use to screen for OCD is, do you have recurrent intrusive thoughts that you are not able to control, or behaviors that you might do over and over again to control these thoughts? That this question looks for both the obsessions and the compulsions. Trauma is associated with multiple psychiatric conditions. It's a cardinal component of PTSD and is also implicated in multiple other anxiety disorders. As well, patients with depression will frequently have a history of some sort of trauma. The types of trauma can be various, including being a witness to war, being abused, being a witness to abuse, being part of some sort of natural disaster, or being part of some sort of accident, whether it's an industrial accident or a car accident or whatnot. To screen for this, I'll simply ask, for some patients, the word trauma has a deep personal meaning. Does this word have any significance to you? The two cardinal symptoms of psychosis are frequently hallucinations and delusions. Hallucinations are the sensory perception in the absence of external stimuli that is similar in quality to a true perception, i.e. seeing things or hearing things. To screen for this, I'll ask patients, do you hear things that other people cannot? Delusions are fixed false beliefs that is out of keeping with a person's cultural or religious background, and is firmly held despite incontrovertible proof to the contrary. To screen for this, I'll usually ask, sometimes when people get stressed, they feel like others are plotting about them. Does this apply to you? This screens for paranoid delusions, but there are other ways to screen for delusions, and there are multiple types of delusions. Often the screening type question you choose will be individualized for the patient. It is extremely important to do a safety assessment for patients with a primary psychiatric condition to ensure they don't hurt themselves or hurt anyone else after their visit. For a suicide assessment, I'll ask patients, have you ever had thoughts about harming or killing yourself? To see the likelihood of them harming somebody else, I'll ask the question, have you ever had thoughts about harming or killing someone else? If they say yes to the question, you have to get an idea of how likely it is they're going to hurt themselves. Some patients will have passive ideas, such as, I wish I wouldn't wake up in the morning, but have no real plans of acting on them, while other patients will have active ideas for this. Instead of thinking, I wish I wouldn't wake up in the morning, they start having ideas about how they're not going to wake up in the morning or how to end their life. If they're having an active ideation, you need to see if they actually have a plan and their willingness to carry through their plan. You can look at their plan and determine the realism of it. It's important to ask about firearms and also ask about driving, as these are two common ways where patients can seriously harm themselves or others. Whenever you see a patient with a mental health issue, I encourage you to ensure that you have an organized approach. So just to summarize, you can use this approach or something like this. Turn your page on your side and make sure you get the ID, chief complaints, and HPI, and you get the patient story by using an OPQRST framework, and everyone should get a 5. Ask everyone about their mood and other sort of physical symptoms by capsing them. Think about the differential diagnosis for a mental health issue and do a MOPS, past medical history, family history. The past psychiatric history will tell you what's been done already. The family psychiatric history will tell you what they're at risk for. Make sure you have a good medication history as always, and to understand their social history, go through that serial acronym. They'll hit off most of the major points. Lastly, I'd like to say that over the years I've picked up a particular set of skills. So if you're seeing a patient for a primary mental health issue and you do not do a safety screen, I promise you, I will know and I will find you.